specialist. As I said earlier, he had the vision in 1985 to come down from the Joslin Clinic and bring the Joslin model, which was sort of avant-garde at the time of managing diabetes, to Palm Beach County. And it's on his shoulders that our practice has grown over the years. Bill did his medical school training at Brown. He then did his fellowship at Cornell. And he's actually, I think, only one of 3 people in the country that's triple boarded in internal medicine, nephrology, and endocrinology. He started out as a nephrologist and then sort of saw the wisdom and converted to the light side and became an endocrinologist. So please welcome him for the last talk of the morning.
So before I begin, Dr. Horowitz, who does the housekeeping today, is no slouch. I just want to mention he went to, did his fellowship at Columbia, he did his undergraduate at Cornell, his medical school at Albert Einstein. He types faster than any doctor I know. He has excellent managerial skills, and he's an excellent clinician. And no one else was going to say that because he's the housekeeper, and I just thought I'd say thank you, housekeeper, and that's it. All right. And also, before I start, and please bear with me, everyone just stand up and go like this. No. 1 second, just go like this. This is if you stand up and go like this is an endocrine phenomenon that happens. Okay, your cortisol is secreting. You're all becoming alpha and beta people. Excuse me, all alpha. So women and men, your cortisol is going up, and unfortunately men, the testosterone goes down. Sorry, I was mentioned. So, I'm going to advance the slide, and the purpose of this lecture is to illustrate what type of patient might be a good candidate or a bad candidate for thyroid replacement therapy, whether we're thinking conventional or whether we're thinking combined therapy. I also just want to add, in case anyone recognizes that I don't pronounce my R's, it's because I come from Rhode Island. So I might say talk and car, I might say I might have a good idea. Just kind of like factor that into your understanding of me. Thank you. So here are my disclosures. I do speak for several companies, including the famous AbbVie, based thyroid medication. I have no psychiatric training, and I do not hold a neuroscience degree. However, I did sleep at a Holiday Inn last night. And I'm speaking about Holiday Inn today, I think. So, group poll. How many doctors in this conference room, nurses in this conference room, have seen patients with poor responses to thyroid hormone? A raise of hands if you have. Oh, excellent. A lot of hands went up there. How many of you have seen patients insistent they have thyroid disease, but you feel they do not? So why is this happening? So we're going to talk about that today. We're going to talk about 3 cases. I'm going to do this quickly. You'll get one soon. Hypothyroid patients with residual symptoms following standard treatment. That will be case 1. Case number 2 will be a patient with multiple somatic complaints, convinced that they are thyroid-related complaints. And patient number 3 will illustrate the potential perils of a non-comprehensive evaluation. So, case number 1, 57-year-old female with weight problems, fatigue, low mood, concentration issues, was found to be hypothyroid. And here, whoops, that's the pointer is which one, Dr. Morris? The middle. The middle one? And here we see her free T4 was in the normal range, but her TSH was 10. So because of the elevated TSH, she was diagnosed as being hypothyroid. Good explanation for her symptoms, correct everybody? Now her primary care doctor or nurse practitioner or anyone who was allowed to give this treatment treats her with L-thyroxine, which is T4. They give her 100 micrograms, and they see her in 2 months. And her labs come back, the free T4 is 1.4, it went up from 0.9. The TSH went down to 3.9, which is normal range of many labs. But she still complains of weight issues and mood issues, and her doctor, who attended today's lecture, recognized that she's in the kind of like low normal group. And can I just say something, breaking away from this case real quickly? There's about 10 million people with hypothyroidism in the country, and there's only 3,000 endocrinologists. You guys are the first treatment modalities. 80% of these cases you're going to handle. But you can see from our group, our multiple talented group, we have experts in hyperthyroidism, in weird thyroid tests, and pregnancy. Those are the cases, the weird cases we're going to help you out with by phone calls or true referrals. But you guys are the gatekeepers, for sure. So anyways, this individual was treated down to a TSH of 3.9. She's still complaining of mood issues. The doctor attended this lecture, so he knows that he needs to push the altithyroxine a little bit more. They increase it to 125 micrograms. They see in 6 weeks. And now look at this. Her free T4 is in the upper limits of normal range, and the TSH is a 0.39, but this individual still complains of weight, fatigue, and mood issues. So this gets into the whole area of concentration of whether T4 is good enough. Now, Dr. Kaye went through the pathways of conversion of T4 to T3, and I'm not going to repeat that in the sake of time. But in my review of multiple studies, including most recent studies, and in my experience, about 10 to 15% of individuals who are treated for hypothyroidism who do not have other confounding conditions like sleep deprivation, using the computers or iPhones late at night, sleep apnea syndrome, melancholy. About 10% of individuals seem not to have an ideal response to plain old standard therapy. So, the American Thyroid Association, both the American Thyroid Association and the European Thyroid Association, they have similar ideas of how to treat hypothyroidism. Both of these entities recommend L-thyroxine first. The American Thyroid Association kind of takes a firm stance and says it's first, second, and third, whereas the European Association is a little bit more liberal in their recommendations. They say if T4 therapy is not working once you've ruled out other diseases and you've treated your patients to the max of the T4, if that doesn't work, then you can go ahead and try T3. Now, the American Thyroid Association is kind of loosening up a little bit, and in a combined statement with the American Association of Clinical Endocrinology, they came out and sort of said the same thing. First T4, but if the person is not responsive and everything else is ruled out, you can consider, although they go on to state it's not proven. So, good candidates and bad candidates. Now, this is not, sorry, stop crying, dry those tears. This is not a political talk, but when I Google in good candidate for free T4 therapy, I actually got a whole bunch of hits on Hillary Clinton. And I'm not her doctor. I don't know if this is true news or not true news, but it's all over the internet.
Alternative facts.
So if you have a patient who's tired and they have difficulty losing weight and difficulty concentrating, and their TSH is close to perfection and free T4 is normal, this might be a good candidate. So, now, that's the whole mixed thyroid hormone replacement versus optimizing the T4 controversy in a nutshell. But let's take a harder case, because I can see that when all of you got your cortisols up, you also increased your IQ points by about 6. You're all sharp individuals. I see it from up here. So take this case with me, and we're going to show raise of hands in a moment. 34-year-old female presents today for self-suspected thyroid issues. The patient states that she's been to several physicians, all who do not know what they are doing, and nearly killed her. She indicates to you that you are her last hope. She states that her thyroid test is normal, but she's been reading on the web that you can still have thyroid problems even with normal tests. Her symptoms include severe and chronic disease, muscle aches and pains, palpitations, weight gain, hot and cold feeling, brain fog, difficulty concentrating, thyroid with constipation, shortness of breath, migraine headaches, palpitations, etc., etc. How many of you have ever seen a case like this? Wow. Wow. It's a good thing you're at a thyroid lecture today. So she brings with her a large amount of medical records showing the results of multiple blood tests and procedures, all of which were non-revealing. They include CBC, SED rate, metabolic profile, thyroid function test of normal, ANA, rheumatoid factor. She's had an MRI of her brain, upper and lower GIs, EKGs, flow monitors. She's had a cystoscope for irritable bladder syndrome. She denies depression. But she feels less depressed about her symptoms. But she feels depressed about her symptoms sometimes. Other doctors have tried multiple antidepressants, but she immediately had a bad reaction, and these are what nearly killed her. She indicates clearly that no doctor will listen to her because they all think she's crazy. But she has done her reading, and she wants you to draw special thyroid tests of her, including things like reverse T3. How many of you have seen this case? So you see that? She knows that some cows had these type of issues and was put on T3 and lost 30 pounds. So why does this patient believe they have a thyroid issue in the first place? And how did Waters get so many? Kind of a simple thing like a hypothalamus controlling the pituitary controlling the thyroid with great blood tests and good medicines. How do we get beyond that to these muddy waters of combination therapy, normal thyroid function tests, feeling badly? So the reason that we are in this predicament now with the patient being their own advocate is that if they simply go into the webs and many of them believe this is a conspiracy, that there are 5, 10, or 15 things that your doctor is not going to tell you, that thyroid function tests are meaningless, that the doctor doesn't listen to you. And there's actually societies and foundations that if a doctor uses a lot or enough of mixed therapy and he pays an annual subscription, they're listed as good thyroid doctors. And I actually checked one of these. I don't want to get sued by slamming a website. But I actually checked one of these websites recently. There's 3 doctors in West Palm Beach that were on that, 2 of whom died over 5 years ago. So they're reading my TSH is normal. Can you have hypothyroidism with normal tests? Yes. And they're hearing that it can cause them fibromyalgia, it causes them irritable bowel syndrome, and migraine headaches. So this is why you're seeing patients with irritable bowel syndrome, migraine headaches, and fibromyalgia claiming to you that they have thyroid problems. They want you to do special things for them. So Dr. Dennis Wilson, an MD, came up with a theory. He saw patients with multiple symptoms, fatigue, migraine, irritabilities, decreased memory, decreased concentration, sex drive, unhealthy nails, allergies, brittle nails, slow healing, heat and cold intolerances, on. And he came, and also low body temperature. And he came up with a theory, well, my goodness, body temperature, thyroid, they're connected, so let's go ahead and give Cytomel, long-acting Cytomel, and he gave Cytomel to XYZ amount of patients in a very small clinical trial, and some of them said they did better. So he extended his theory to say that, well, if your body temperature is low, the human body enzymes can only act at 98.6. So you're having enzyme malfunction in your body because of low body temperature, and if you simply give, Cytomel, you're going to stand up straight, you're to say that every single credible medical society has come out and said that there's no such thing as Wilson's temperature syndrome. But this is what your patients are reading. And this is why they're asking for T3 more often than is clinically indicated, which is a small percentage, but a significant percentage of the time when you consider that 10% of people don't respond to thyroid hormone. But that's not what this case is about. So depending on what type of legitimate doctor saw this patient, they may receive several different diagnoses. You might have to code these with your electronic medical records. Chronic fatigue syndrome, depression, irritable bowel syndrome, fibromyalgia, medically unexplained symptomatology, functional somatic disorders, somatoform disorders, or central sensitivity syndrome. Now, I told you I'm not a psychiatrist, I'm not a neuroscience, but I can tell you one thing. In my experience, these patients that come in, and they're almost like they read the same book, or they're from the same planet. There's got to be something to it. Their symptoms are so similar. I mean, different but similar, but confusing. So when people present with multiple somatic complaints, such as female urethral syndrome, primary dysmenorrhea, chemical insensitivities, restless leg syndrome, TMJ, tension headaches, GI functional disorders, chronic fatigue, we're finding that all these syndromes can be lumped together using a unifying neurological hypothesis called central sensitization syndrome. These people are not malingering, and they're not crazy. The emerging field of neuroscience is getting a better understanding. Remember, we're only in the year 2017, and SGLT2 inhibitors, that make glucose in the urine, only came out a few years ago. Before that, we didn't know about the kidneys and the control of sugar. So things are emerging rapidly, but we're still in the infancies of medicine. So central sensitization syndrome is the syndrome that these patients can be termed when they have multiple somatic complaints like the ones I discussed. But if you look closely at a hypothyroid individual, they have multiple somatic complaints too. So the patients and the doctors kind of get these two syndromes confused. But if you look very closely at individual symptoms of someone who has this central sensitization syndrome, mind you, this is a new word to group all the functional disorders together. They have, palpitations, which are not seen in hypothyroidism. They have gas, which is not seen in hypothyroidism. They have sugar cravings, which is not seen in hypothyroidism. They have panic and anxiety attacks, which is not. So, even though there are some overlapping symptoms, there's a clear-cut, difference. So, if the patient says to you, I'm hypothyroid, and starts rattling off 20 symptoms, don't necessarily believe they're hypothyroid. You've got to think critically. So, this central sensitization syndrome is a true syndrome that individuals have heightened sensitivity at the affected site, or hyperalgesia. And also, beyond where they primarily hurt, they have increased sensitivity. And after you touch these individuals in various spots of this discomfort, the pain might even linger. And their pain lingers beyond explanation. And this is occurring without observable physical signs, and it's often comorbid physical symptoms. Fibromyalgia is a prototypical disease of central sensitization syndrome. Many years until this condition was recognized and legitimized by the Rheumatological Association. Now, I'm not going to go into it, but there's a definite criteria for diagnosing somebody with fibromyalgia. And there's two FDA-indicated medications. There's Lyrica and Cymbalta. So, in the field of neuroscience, and I told you I'm not a neuroscience, but it seems as though when an individual gets an injury to a nerve, there are some individuals that are susceptible for actual neurochemical changes in the spine spinal cord, which causes amplification of pain signals to the brain. And the brain, with neuroplasticity, focuses on memorizing this pain. Rather than the pain being persistent and you kind of put it on your mind, it becomes more prevalent to susceptible individuals. And the brain loses its ability to subdue or suppress the pain signals. So I'm not going to get much into this, but sensitization syndrome is a neurological syndrome that you can read about in your spare time, and it explains why individuals go from simple pain into chronic pain, often in multiple areas of their body. Here's a fantastic study that was just done in Europe. They took volunteers and they flashed in front of them visual cues at the same rate as their heartbeat. Okay? So I'm looking at a picture of a mountain. My heart's going at 80 beats per minute, and this picture of the mountain is going at 80 beats, per minute. Turns out that if you show somebody images at the same rate as their heart, many times they miss those images if it's perfectly correlated. And if you actually do functional MRIs on these same individual, and you show them the visual cues, their functional MRIs don't light up and show you that they're seeing these cues. So this is all happening in the insula of the brain. So the theory is emerging that the brain actually has a filter that filters out signals that can be distractions, such as your breathing, or your heart, or the fact that your hands are cold and your feet are cold, or your stomach is gurgled. Because you can imagine from an evolutionary perspective that if somebody is being bombarded, by all these symptoms, they're not going to see the tiger ready to lurch, and they're not going to be alert. So this is a protective mechanism that will filter out all these body symptoms. But if something goes wrong with that filter, these symptoms can be perceived and make the patient like the patient we're talking about. And the field of medicine is going to be classifying central sensitivity syndrome into a new disorder. It's going to be called bodily distress syndrome, and you're going to see this in the ICD-11 coming out, going forward. So nobody knows who these people belong to. Do they belong to Lucy, the psychiatrist, or they belong to Dr. House? But these people who are presenting with multiple somatic complaints probably have a combination of genetic, psychosocial factors, and biological factors. But I'll tell you one thing, these are not the people that we're saying treat with T3. We're talking about the fatigue, the brain fog, a little bit of a sense of well-being of being off. They might be candidates, but not the multiple somatic syndrome individuals. So experimenting with thyroid preparations can lead to harm in these individuals and side effects. The patients will continue to see multiple specialists if this syndrome is not recognized. They'll be costly for them. They'll seek alternative therapies, and they might even become belligerent and combative if you tell them everything is normal, they don't have an illness. If you could read down here, is Prince Charming, trying to wake up the princess, and he says, how come you won't wake up? And shut up and give me my thyroid pills. So anyways, I just want to say how I handle these difficult patients in terms of words. And you should never ever lie to a patient and make up a syndrome. But emerging science has gotten us to the point where we can explain some things to this patient. I relate to the patient that I don't think that she's crazy or that it's all in their head. I explain that neuroscience is in its infancy and we have a lot to learn. And it might not be tests for this complaint if they're neurochemical in nature, if they're serotonin, if dopamine, if acetylcholine, and gamma-aminobenzoic acid. There might not be tests to diagnose this condition. I talked to them about the filter theory that the brain might be allowing normally filtered out sensations to enter consciousness. I discussed that being sensitive to multiple medications is just another sensitivity, like you're sensitive to your heart. And if I do decide to use an SSRI or an SSNI, if I take it, if I'm truly their last hope, they won't go see a psychiatrist, I'm going to use a Prozac-like drug or Cymbalta-like drug, I explain to the patient, I'm not necessarily giving it to them because their primary issue is depression. I realize that they have a biological disorder, probably body distress syndrome or chronic sensitivity syndrome, and that we're using this medication for that, and that this office thinks that they're crazy. And we started a very, very, very small dose of these medications, and we tell the patients, expect the side effects, because if you're getting the side effects, it's kind of more proof that there's a filter issue. 2 more slides, by the way. Explain that there might not be any relief for 2 weeks, indicate that the treatment is not permanent, and if they get resolution of some of the symptoms, it might shed further light on what other residual conditions they have. Don't force this recommendation. Tell the patient what your feelings are and let them sleep on it. All right, case number 3, last case. This case I actually just saw recently. This is just amazing. A 60-year-old dentist, after being to numerous doctors, presented with temperature disturbances to me and my allergies. The exhaustive workup by his physicians yielded only an elevated gamma-globulin level. He brought a stack of tests, ladies and gentlemen. He related that he had a positive Lyme disease test, and this was the leading diagnosis. And he read on the internet that he could get temperature disturbances and aches and pains in the muscles, so he made his way into the endocrinologist's office. At the end of the evaluation, I did not know what was wrong with this man. He seemed very, 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 with it, studious, and legitimate. So I made a phone call to a tertiary center, since he's been to multiple specialists already, and I struck out like a bad luck. Their rheumatology department was closed, and the infectious disease department was closed. And I called him up and I said, I'm struck out, I'll work more with you. The gentleman got himself into Johns Hopkins, but before he could go to the Johns Hopkins evaluation, he collapsed and was brought to Jupiter Emergency Room, where he was found to have a hematocrit of 20 and a very large cardiac murmur. He was diagnosed with subacute bacterial endocarditis. He received IV antibiotics, and he actually had a mitral valve repair. He came back to my office a couple months later, and I was looking through his chart, and I said, hey, what happened to you? What was wrong with you? And he said, well, I had my heart fixed. So here's the point. People are coming with preconceived notions. They take 2 or 3 symptoms, they diagnose them with something. It's our obligation to think critically. I did think critically of that gentleman. I knew it wasn't thyroid, and I believed he had an illness. I sent him to a multi-specialty group. But I had simply say, oh, you've read too much on the internet, goodbye to you. That would have been it for him. So when these patients come, you need to always think critically. You think the common. You think, did you get enough, sleep? Are you depressed? You rule out the anemias. You rule out the common conditions. You rule out sleep apnea with the obesity epidemic going on in the United States. But the one thing to remember is that people are coming with preconceived notions. And you also have to remember that you've heard here that doctors are missing diagnoses and here's the magic treatment. But it's not really like that. What it's really like is that you critically look at every patient that comes to you and you proceed accordingly. Thank you very much. Appreciate it.